Great learning from three speakers. So, as it is definitely less in these days, with me, Dr. Pathak is only there. So, he is a great teacher. He taught us also when we were student. So, Pathak sir, you have any comment? What you saw this disease when
Uh,
in your
uh,
teaching?
all the three topics have been excellently covered, first by Dr. Avik Karak, second by Dr. Vedanjal Roy, and third by Dr. Mon. And Dr. Avik Karak touched upon the importance of echocardiography in making a diagnosis of that specific problem. Uh, Vedanjal Roy uh, used upon the optimization of fluid therapy, very important part of the management of this patient. And regarding Dr. topic, it was that advanced cardiology, and it is beyond the scope of treatment for the internists like us. And the mic chairperson for that.
No, that's fine. But we learned at least a lot of things because the immunomodulation, what you have emphasized, was not there decades back. And also, the other thing is we should not jump into doing a pericardiectomy very smartly. The outcome is not that good. Third important reminder is that empirically treating this patient with antitubercular is not the way to go. Definitely, we can have a thoracoscopic guided biopsy, but that's all. This is definitely a good topic and it has a lot of clinical twists. So, in absence of others, Dr. Soumitra Kumar, you wanted to say, highlight something on this or anybody that in. One thing is clear, some noise is coming. So, one thing is clear that if it is not a constrictive pericarditis, we assume that this patient has a constrictive pericarditis, but on the background of intake of ethanol and risk factor for coronary artery disease, will you think of primarily a dilated left ventricle and a right ventricle also? We don't see in clinical picture. Again, that is a myth that alcoholic cardiomyopathy exists or not. We can see some B1 deficiency in some of the cases. Another case I can remember who had a myocardial infarction where all the septal got occluded, and these patients came with a very big scar in the exclusively septum, and the septum became patulous, and he presented with recurrent right heart failure with a severe tricuspid regurgitation. But this only can be addressed by doing a good echocardiography, and even the cardiac catheterization has been less utilized in these days because you get all the information with a combination of echo and cardiac MR. So I think the things here to go, and we don't know the association of AIDS related complex and constrictive pericarditis. Also, this is not being reported very clearly because these patients can have multiple comorbidities. It is difficult to say. But anyway, now onwards, if we found constrictive pericarditis, we have to think of this newer molecule. I don't know, Sumanto, whether these are available in India or not, but definitely this is a good option. So, any other
AIDS-related
questions?
pericarditis, some data are there, AIDS-related pericarditis, and not constrictive pericarditis, but recurrent pericarditis do occur in HIV infection, and heart is the treatment of choice. They are recommending that heart patient should come to continue that heart and do a CMR and see what is the inflammation status over there. And I mean, before going to pericardiectomy, they're promoting heart only. Usually they are reversible with heart.
Yes, Professor Kumar, you are saying something.
Yes, I mean, this problem was in fact, coined by me, the problem, case problem. So I had other things in mind also. So Shumamto has mainly highlighted the pericarditis part of it, but we should not forget the restrictive cardiomyopathy predominantly affecting the right heart. We are going to get a deep Y wave and other features there as well. And the severe TR, which was highlighted by, I mean, it basically primary TR, and often it can be induced by some device leads and other things. Ultimately, the severe TR becomes a problem. So I wanted Shumanto to highlight those problems also. Anyway, you can briefly touch upon those. I mean, how you are going to tackle those problems.
Yes, sir. So, apart from constrictive pericarditis, we can have a dilated cardiomyopathy affecting the right side, one, and number two, restrictive cardiomyopathy with affecting right side, and alcoholic cardiomyopathy and primary TR, or TR producing right heart failure or cord pulmonary. So these are the DDs we checked. And apart from constrictive pericarditis, because this is a totally different one, there's a mechanical, constriction or compression. That's why we are, discussed this thing. The other things which are dealing with the valve one, if we consider the valve is the main culprit here, primary TR or TR producing these symptoms, then we should look for symptomatic improvement for the tear, as Dr. Shilanjan has discussed. Next, the surgeries for tear, tricuspid valve replacement, tricuspid annuloplasty, and now the interventional goal, the trick valve and these things to deal with the primary tear or tear. Just valvular pathology. But if it is secondary to PH, secondary to left heart disease, and secondary to RV cardiomyopathy, then it is very difficult to treat. In this case, devices, I don't know what is the status of devices in these cases due to secondary to some other issues. So, usual anti-failure managements and ultimately leading to heart transplant is the usual approach. If not, we should go for a CMR to look amyloidosis and sarcoidosis. If these are the culprits, then definitely they have some definitive therapy. We know that thing. And apart from this thing, valvular pathology has some, advanced and specific focus treatment.
Yeah,
Yes,
the
thank you. Now
one
you have covered
condition.
the entire spectrum.
Yeah. And also, we have seen cases where you have a postpartum infective endocarditis or patient with a lead or chronic indwelling catheter because of end-stage renal disease or chronic chemotherapy. And I've seen few cases where the tricuspid regurgitation is severe and there is no active infection, but the mass is there. And it's difficult call for the surgeon also because they are high risk for surgery as well. So these are real challenges, and maybe we are seeing these patients also most frequently, if I pointed out correctly, Dr. Kumar. So those are the other things. So if we are having no more discussion, we can end and go to the next case. And before we close, Ovik, Shumanto, and Shilanjan beautifully presented, gone through a brainstorming session, which is actually deserved this cardiac heart failure summit, deserve this sort of discussion, because we need to go to the detail. And these are the cases which is not being studied in heart failure pharmaceutical pharmacological approach therapy. Nobody knows that the effect of ARNI or SGLT2 or MRA in the primary right-sided heart failure. So they are really challenging. So with this, I think I conclude, and organizer, please take the next case forward. Thank you again. A big hand silently on the screen only to all three of you. Thank you.
Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. Banerjee. Thank you all respected panelists and chairpersons. Thank you, speakers. And with that, we will move on to our next session.